to talk about basically, I'm going to focus more on sort of health services and health intervention. In this talk, so I'll talk about some of the disparities that we found in healthcare and healthcare services for children, and then also disparities in health outcomes, looking at children there. And then the importance of culturally tailored intervention, which most of you know the importance of it, but I'll just go over some points about that. And then I'll give you an example from a study that we just wrapped up, and we're going to, we just finished randomized controlled trial. So we're writing that up, so excited to talk about that. First, I'll talk about a study. I worked with Susan Parrish. I don't know, I know Len knows Susan Parrish. We did a lot of work looking at national data. And so we looked at the National Survey of Children with Special Healthcare Needs, which is a data set that came out every 4 years but doesn't exist anymore. Now it's just there's just the National Survey of Children's Health. But we looked at quality of healthcare, and we actually looked at two different time points. So I believe 2006 and 2010, and we pretty much found that there had been no change in those disparities existed. If you look at the kind of quality indicators here, it's like providers helping parents feel like a partner, providers spending enough time with the family, providers sensitive to family values, and providers listening to the parents. So those are some of the quality indicators, and we found that compared to white, so white is the blue, orange is black, and then gray is Latino, that pretty much all of those were significant, especially for black compared to white, and some of them for Latino compared to white, in terms of having lower quality of healthcare. And then we looked at interactions, but also healthcare access and utilization in addition to quality, and kind of looking at disparities there. And so we found in this study, we looked specifically at Latino families compared to white. We found that, of course, that Latino families were less likely to have health insurance, so that's an access indicator, and does not have usual source of care was something that was more prominent for Latinos. And then in terms of service utilization, difficulties using services, they're more likely to have those difficulties and problems getting referrals. So those are some of the differences. It'd be interesting to look at the National Survey of Children's Health now to see if those disparities still exist, right? So from that survey, they did in 2010, in 2011, they did a survey called Pathways, where they looked specifically at autism and IDD and more specialty healthcare specialty services, so like behavioral services, occupational therapy, those kinds of things. And so one of the things that we were looking at here is, it makes sense that if a child has higher support needs, they would get more services, right? I mean, that's logical. So we wanted to see how that played out. And what we found is that that was true for the white children, that if they got more, if they had higher support needs, they got more services. But for Latino children, there was no difference between high and low support needs. So that was an interesting finding. And then using that same data, the Pathways data, we looked at what kind of guidance are providers giving to families when they bring a concern, right? So they bring a concern, is the provider then giving them a referral, or telling them, doing a screening or some kind of proactive response, or what, are they telling them something more passive, like, well, let's wait and see? Or it'd be interesting to see right now, what percentage of physicians actually do a proactive versus a non-proactive response. But with this data, what we found is, first of all, that the white children were getting more of these specialty services than the Latino children. But then looking at the provider response, so the active response are the ones I mentioned, like maybe they refer them to the school, or they refer them for an evaluation, or they do a screening. Passive responses were like, let's wait and see, or they'll grow out of it, or those kinds of responses. And there were not significant differences, but interesting that the white parents seemed to report more of an active response and non-active response, right? But those weren't significant differences. So it wasn't that providers were telling Latino children something different, but what we found is that if the provider, and the red line is Latino and the blue or black line is white. So we found that if there was any kind of passive response from the provider in these, they could give passive and proactive at the same time, but any kind of passive response, the Latino children received fewer services as a result than white children. So to me, that kind of says that providers, especially with underserved populations, really should be proactive all the time. They should give proactive responses versus these kind of passive sort of responses, because it does make a difference. So now I'm going to talk a little bit about health outcomes, and that's something that I think we need to do more research on in terms of children and adults with intellectual developmental disabilities. We've seen research that has looked at disparities in diagnosis for autism, right? Specialty services, healthcare. So there's a lot of research out there doing disparities, but we do need more research on these health outcomes, looking at physical health, because we do see, they have a lot of co-occurring, health conditions, and so it's important to look at those. And also looking not just, I think it's important to look at children with autism versus children who don't have autism and those disparities, but also within racial and ethnic groups or other populations. So I worked a little bit with the Healthy Weight Research Network. Some people may be familiar with that, with Aviva Must and Carol Curtin and that team. And we did a study looking at obesity among boys with autism, and basically using the ABCD study, using that data. And some people here are familiar with that data. At the time, the kids were 9 and 10, the data that we looked at. And we selected boys only because it was such a small sample of kids with autism within ABCD study. It's a huge study, but the kids that were identified with autism is smaller. And so we felt like we couldn't represent girls very well. And then we made sure we selected boys that were also, their parent was of the same heritage, basically. And so there was a total of 123 kids with autism, and 84 that were white, 18 Latino, and 21 were black. And what we wanted to look at was BMI score, body mass index score. And so we found that, that compared to the white boys, Latino kids had much higher rates, and black kids had much higher rates of obesity or higher BMI score. And you can kind of see that pattern here with looking at overweight and obesity, and then also obesity by race and ethnic group. So overweight and obesity put together, we found the same pattern basically across both of those indicators, where the black and Latino kids had higher rates of obesity. So it's an area that, and in the literature, if you look at the literature with black children in general that don't have disabilities and Latino children, they do tend to have higher rates of obesity in general, not just with disabilities, but maybe it's more prominent, having autism. Now, another study we did just recently was looking at the full range of weight status. So, they have these categories of weight, like, let's see if it says here. There's underweight, right, normal weight, and then there's overweight and obese, right? But researchers are thinking that obese category needs to be further defined, because there's people who are really overweight or obese and children who aren't. So we tried to look at that full range. So we actually combined the ABCD data along with the National Survey of Children's Health data to make a larger sample. and we had a match sample to compare them with. So we had pretty large numbers there. And these are the weight categories that we used, so, and how they're sort of determined, right? Underweight, healthy weight, overweight, mild, moderate obesity, and then severe obesity. And so we had to get special permission from CDC because they don't give you the BMI data. They just tell you the categories, what percentage are in what categories. So we had to write a proposal to get the BMI data so we can make that severe obesity category. ABCD did have BMI data, so we were able to use that. But so this is we looked at within groups. We didn't compare groups, but we looked within Latino, within Black, within white, and within Asian. So I'll show you those in a minute. But what you see here is that there's significant difference in the underweight category, right, where the children with autism are blue, the gold are the children without autism. So children with autism are more likely to be underweight for both Latino and Black children. And then at the other end of the spectrum, that was also a significant thing, the severe obesity category, right? So children with autism were likely to have severe obesity compared to children who didn't have autism within each group. Some of the other categories were not necessarily significant. Maybe the healthy weight category was significant for the Latino children here. And then looking at white and Asian families, we see that really a similar pattern, except with the Asian kids, the underweight category was not significantly different. But we did see that difference at the severe obesity rate. So very similar patterns across race and ethnicity there. So yeah, I mean, weight and obesity and things like that, I mean, sometimes it's hard to talk about it. A lot of people don't like to think about the negative implications of those terms and stuff like that. But it is important in terms of health of these children because it can contribute to all kinds of health problems, whether it's, heart problems or other challenges that they may face later in life, right? So we had a study, it was a Neidler DRIP, they call it a DRIP. So it was a 5-year study where we did multiple different studies. And so we did a cross-sectional study with Latino kids and their families looking at health. And then we developed an intervention and tested the intervention. So I'm going to talk a little bit about both of those things. And this is our team. We did this across Illinois, University of Illinois, Chicago. My colleagues there, Yolanda Balcazar and Mancha Mirza, and then our UT team. Some of the UT team moved to other places like Colorado and Santa Clara University, but they were started at UT. But we had a great team for this whole period. It was really good. And so our first paper with the cross-sectional data, we were looking at BMI of the kids and what contributed to that, and we were looking at parenting strategies related to diet and related to exercise. And first of all, I want to say, if we compared our Latino sample, that we recruited for this compared to what was in the literature, and you can see that the blue was our sample, and it's pretty high on obesity status, like 60% of the kids. And then it's even higher than the orange is Mexican-American children, so they have high rates of obesity, but our sample was higher. And then we know that autistic kids compared to non-autistic kids have higher rates. So you can see that it's sort of like an intersection, right? Intersectionality issue, right? Where if you combine autism and being Latino, it really confounds the situation. So relating to the diet strategies in the health sort of behavior research with kids, the idea is that monitoring is better. So if the parents are monitoring their child's diet and sort of providing guidance and input, that should be better. Controlling is bad because that's where you're controlling everything the kids eat, or you tell them to eat everything on the plate, right? My parents did that. But I don't know if any of your parents did that. But we actually found with this sample that controlling was better. So we found that parents who used controlling strategies, the kids had lower BMIs. And then parents whose monitoring strategies, actually that was associated with higher BMI. So it's kind of interesting. I mean, it's a sample of about 100 kids and their parents. And it's not clear to me whether that's related to culture or whether it's related to IDD and it was mostly an autism sample. And so it might be, may tell me if this is crazy, but it might be that since kids with autism have a lot of sensitivities to food, and they don't eat a lot of different things, right? They eat maybe French fries and other things like that. That having them eat everything on the plate, maybe they get more variety of their diet. Who knows? That needs more exploration, but that's one of the things we found there. And then this is one of my grad students. It's now assistant professor, but he looked at social determinants of health, and he's looking specifically at maternal outcomes like quality of life and family functioning in this same sample. And so this gives you a better picture of what the sample was too. It's 105 kids and parents, sort of dyads. And you can see the parents are mostly low education, 45% high school or less. They were also very low income. And the moms were about 42 years old on average. The children were about 10 on average. We recruited kids between 6 and 17. And interestingly, the kids were mostly born in the US, right? But the parents were mostly born outside of the US, mostly Mexican descent. In Chicago and Texas tend to be more Mexican American. And then, and the kids had high rates of having Medicaid. I'm just going to explain this to you. It's kind of crazy numbers. Should put this in a better format. But there's two models, right? Model one is quality of life, as the outcome, and model two is family functioning. So looking at those two models, and we can see, some things you might expect, like maternal age and chronic health conditions of the mother are related to lower quality of life, but some of the social determinants of health that haven't really been examined in this area, home ownership. So if the families owned their own home, they had better quality of life. I mean, that makes sense, right? But and in the general literature, that's true. But in the race and ethnicity literature, it's actually not true, because owning your own home might not, if you live in a neighborhood that has low quality of life neighborhood, it may not increase your quality of life. So, but for this sample, it was, that's something we could do something about, right? Like, let's help these families own their own home. And then food insecurity was another one that if they had more food insecurity, they had lower quality of life and lower family functioning. Also perceived discrimination. So these are the parents and their perception of discrimination. So that was related to lower quality of life and family functioning as well. On the positive side, family cohesion was related to better quality of life and better family functioning, and so was social support. So those are things that we can build on, right? But we did want to see if there was like a buffering factor for social support, and we actually didn't find that. We found that actually perceived discrimination was kind of dampening, because the social support was related to higher quality of life when there was low discrimination, but when there was high discrimination, it was no longer related to that. And so something we never look at with kids with IDD, right? The extent to which their families are experiencing discrimination. And we don't really know, we do have a follow-up question to find out what the discrimination is, whether it's race, ethnicity, disability, things like that. But we didn't look at that with this, so we probably should go back and look. But yeah, now in this climate, people are feeling a lot of discrimination, right? Yeah, and so for future research in this area, we do, need to think about interventions and culturally tailoring interventions, train professionals on how to work with the families. I will say in these slides, there's Latina, Latinx, Latino, right? And so, I'm not sold to any one of those terminologies. Sometimes our team wants to use one versus the other. But obviously Latinx and Latina are more inclusive, gender-wise, but many families are not really familiar with those terms. I mean, I tend to use the term that families would use more. So, so we really have to think about how social determinants of health are related to outcomes for these families, and what can we do, what are things that we can actually change about that, and then empowering families as well. Culturally tailoring interventions. So people have probably seen this study, and there may have been some since then. This was a systematic review done in 2022 to look at to what extent race and ethnicity is even reported in autism intervention research, right? And they found that only 25% of the intervention studies, those 1,013 studies, reported any data on race and ethnicity or socioeconomic status or things like that. And they did find a trend towards more reporting, later on over time. And then even in the studies, that 25% that did report is not really representative of the census, on those populations. For example, Latinos are probably 19% of the population, and they're 7% in this study. So, in all these studies that reported. And I wonder if that's going to get worse with all the stuff that you can't talk about race, ethnicity, coming from the funders and stuff. I hope not. I hope people will continue to report these things, right? Because NIH did have a focus on you have to report. They have a table. You have to report the race, ethnicity in your data. I don't know if they haven't stopped that, right? It's still, that's good. So these are some reasons why people might be underrepresented from minoritized backgrounds, right? There's traditional mistrust of healthcare providers, and there could be a trust issue that it's different across different groups, right? So, for example, for Latinos, it might be more around immigration kinds of issues, and for Black families, it might be more the historic, discrimination that they've received in healthcare and their experience with research studies. A lot of the research is conducted, especially intervention research, in unfamiliar settings. Maybe it's here at UC Davis, and somebody lives really far away, Del Paso Heights or somewhere, and they can't get over here, and then not being able to take time off work, having other caregiver responsibilities. If you're we're all doing remote studies now, right? So making sure that people have internet and that's accessible. It could be a barrier if not. And then non-English speakers are often excluded from research. Not yet diagnosed. This is something I was presenting to an autistic group, and they brought that up because, a lot of individuals from minoritized backgrounds get diagnosed later. A lot of people get diagnosed later, right? And so they're not in these studies because they haven't been diagnosed. So in terms of why cultural adaptations is important, I think our field is very underdeveloped in this area of cultural adaptation. But in mental health, they actually have done a lot of work in this area of culturally adapting mental health interventions for children and adults. And so there have been a few meta-analysis of those studies, and they found moderate to large effects for culturally adapted interventions, and those conducted in client's native language were twice as effective as those in English. That seems obvious, right? But a lot of times there'll be studies where if people who are mostly Spanish-speaking can speak a little English, they're still included in an English-speaking study, right? But it's not going to be as effective for them as in their own language, right? And then tailoring interventions for specific groups, or they're 4 times more effective than provided to all groups. And that's a challenge we all face. Like, you want to develop an intervention that's responsive to everybody, right? But is that even feasible? I don't know. This research is showing that maybe you have to tailor for each group. So I'm still grappling with that one, because we do a lot of culturally tailoring for different groups. But then how do you do large scale or scale it up kind of thing? And there are a lot of best practices, and many people in this room utilize some of these best practices in terms of developing interventions for different groups. So making sure you're involving members of that community. You're considering, I throw this in, considering peer-based recruitment and delivery methods. I think peers can be very powerful, and I'm going to talk a little bit about that. And then, of course, creating and adapting materials for that specific group, making sure you have, pictures of the kids from that group and so on. The materials also reflect their culture and different things like that. And then accessibility, reducing barriers. And what I meant to say here is we did use the ecological validity framework for one of our studies, but there are different cultural frameworks you could use. So, at least consider using a framework for doing that. And this is just showing the process, because it is an iterative process, right? So, first you want to consult the community about what their needs are and what they want, right? And then you want to select what intervention you're culturally adapting, or if you're going to create one from scratch, based on that knowledge. And then you want to make those adaptations or changes, and then you want to pilot it. So you do a small pilot study to see, if it's going to work, and get some feedback on that. And then after you do a pilot study, you need to evaluate your results and the feedback, and then update your materials and do it again, but maybe in a larger study or randomized control study. So the cycle never really ends, but you could keep going. But at some point, funding stops, and then you have to stop. So we developed the intervention Poder Familiar. So Poder in Spanish means power, but it's also an acronym. I think I showed on a slide previously what the acronym stands for, and I can't remember. It's promoting obesity prevention or something like that. So we wanted to make sure that we're helping families to promote good health within their family, and for the kids and the parents, because the parents also have health problems. And so I had developed an intervention called Caring for Myself, which really focused on the caregivers and the parents, and really focusing on their health. And then my colleague Yolanda had an intervention, Familias Saludables, which focused on the whole family. They did a lot of group things in Chicago. And so we kind of combined our efforts and made one intervention. It was 10, so now we've learned how to do remote stuff from COVID, right? And so we realized we could reach the whole state this way, because if we did it, we did plan to do this in person, but we had to switch everything up because of COVID. So, but you can reach more, like Texas is a huge state, and we can reach people in Houston or El Paso or other places that we wouldn't be able to do if we did it in person. So we had 10 remote sessions, and I'll show you the topics. And they were delivered by a peer mentor. So we call them promotoras, kind of modeled after community health worker, model. But the nice thing is that they are parents of kids with autism as well, or disability as well. And then we had 3 group sessions. We started out doing the group sessions in person, and then we had a hard time getting everybody in one place, so we switched those to remote. But that was basically the intervention. This is a model that was developed in the course of this adaptation. Yolanda Balcazar took the lead on this, but basically it's called the LaREDS model, so really looking at these dimensions like language, accessibility, reflecting values, generational differences, because you might have children that prefer a certain style, and parents another style, or grandparents another style, right, of doing exercise or whatever it is. and then values and ways of thinking, accessibility, and then social, cultural, spiritual environment, and then thinking about the format of delivery. So they actually, so Yolanda led a paper on that, so this model is described in the paper. And what's interesting about it, this is a figure from the paper, and so you can see the Lored's model on the left, but on the right is something that one of our promotoras contributed. So she was a co-author on this paper, and these are things that she did, and we used it for the training of the promotoras in every session, basically, you know, defining the value of the program, building rapport, demonstrating cultural humility, understanding family dynamics, drawing on personal experience, preparing to listen to concerns and help solve problems, and then holding yourself and the caregiver responsible or accountable while giving grace. I mean, this promotora was amazing. She was like really articulate about these things and celebrating accomplishments. So she helped us with a lot of training, the other promotoras as well. So these are the sessions that we used. I mean, you know, it's health. So we're talking about stress management, balanced diet, physical activity, you know, grocery shopping, social support. So these are topics that you would find in a health intervention, but we tried to make sure that they were focused on in the context of having a child with a developmental disability and how do you include them, as well as take care of your own health as a caregiver. And everything was delivered virtually, as I mentioned. And we did have a control group. I'll talk more about that, but this is just showing the promotora model. So if people are familiar with community health workers or promotoras, it really comes from the public health field. You know, and usually promotoras would be providing education around chronic health conditions, like maybe heart problems or diabetes or other kinds of things. And we said, well, why don't we use this in this context or in DD and autism work? And so, but the unique thing, in addition to really understanding the language, the culture, and all of those things, we wanted to make sure our promotoras also had a child with a developmental disability, so they had that lived experience that they could share. And we did extensive training with the promotoras, really doing several sessions of role-playing, going over materials, and going over some of the structural issues in the intervention. We have a manual that we use. Anybody wants to use the manual, let me know, and we can share that with you. So we did a pilot study, and you know, in the pilot study we had, Amy kind of led this. She's a postdoc with us now. She was a PhD student. And so we had 15 families in Illinois, 15 in Texas. 86% of them did all the 10 sessions. And we did find significant changes between pre and post. It was a one-group design on maternal health-related self-efficacy, healthy food index, child physical activities, child global health, and sugar intake. So that was the only dietary factor we found different, but it was important because a lot of Latino kids have high sugar intake because of, you know, the drinks that they're offered, have a lot of sugar in them. So we had good feedback so that we could do that iteration process, right, for our randomized control trial. And these are some of the elements of the feedback that we then incorporated into our next round. So they wanted to see streamlined sessions, enhance the visuals that are, we had PowerPoints, you know, that were used in Zoom, and really enhancing the visuals, and having more interactive elements, making sure that we're addressing cultural relevance and consistency, and then goal tracking. So we did a lot of goal setting. We used SMART goals with the caregivers, and really, you know, needed to do a better job tracking. Did they meet their goals and things like that? So then our randomized controlled trial, and just to give you an idea of the theoretical framework we're working from, so using self-efficacy theory from Bandura. So the idea is you engage in a health education program or intervention. Participants would feel more confident in carrying out what you're teaching them, right? And then from that confidence, then they would make behavioral changes for themselves and hopefully for their children in this case, right? So we are hoping that to see increased self-efficacy from the moms, change in their own behaviors and outcomes, but also changes in the child behaviors and outcomes. These were the research questions for this. We're writing this paper, so this is what we put in the paper. Do the mothers, improve in the self-efficacy compared to mothers in the control group, and do they improve their own health behaviors and health outcomes, and then do the children's behaviors and outcomes improve as well compared to the control group. So this, again, was a 2-site study. Our goal, we were trying to recruit, I talked to a lot of people about recruitment today. It's hard. And so our goal was to recruit 30 at each site and 60, but we got up to 55, basically. So we had 26 in the intervention group and 29 in the control group. And interestingly, of the 26 in the intervention group, 24 had autism. So we weren't specifically recruiting autistic kids. We were looking at IDD, but that's who basically enrolled in the study. And then, so we did baseline assessments and then randomized them. And had some attrition, but not that much. So this is, we did a sequential block randomization where each site, randomized. And so you can see the Illinois actually recruited more people, and they had, so that accounts for the differences in intervention and control group a little bit. But we then put them all together for analysis. And this is what the moms were like. So on average, 42 years old, high school or less education, on average 42%. Income pretty low, about 63% being born outside of the U.S., and high percentage of them being married, many of them uninsured. It's a good number of people who are uninsured, right? And then looking at the kids, they were on average about 10. The female ratio was low, and that may have to do because they were mostly kids with autism, and the diagnosis is still favoring boys in that case. And they were more likely to be public insurance like Medicaid versus private. So the measures we used, so we had the maternal health-related self-efficacy, and that had a few subscales like exercise, nutrition, responsible health practices, and psychological well-being. And then we looked at health behavior. So, one thing, it's not really behavior, but it's like the home environment. Is there healthy food around? Is there physical activity, equipment around? Kind of what the mom does to keep the environment healthy. But we also looked at their physical activity level and their diet intake. Then we looked at health outcomes, including, we used the PROMIS measures for physical and mental health subscales, sleep troubles, perceived stress, and BMI. We didn't actually expect BMI to change, by the way, because it's a short time and it takes a lot to change that, but we're hoping to at least maintain. And then children, we had a physical activity measure, diet intake, and then the outcomes: PROMIS global health, sleep trouble, and body mass index. We used linear mixed models to examine those effects, and we controlled for income level because that was a difference between groups, as well as child diagnosis. I believe the intervention group had more autism versus the control group, and then study site. And so these are our results. We found that research question 1, yay, we got we got research question 1. So, mothers in the intervention study. In the blue is baseline, orange is the follow-up point, right? And so we found that at the follow-up, the moms in the intervention study had higher scores and self-efficacy, but not so much the control group. And then this is just looking at those subscales I mentioned. So the ones that were significant were exercise, and psychological well-being. So those were kind of driving that overall measure. Then we looked at their health behaviors, and we didn't find any differences in exercise or food intake, except fiber was almost there. They were eating more fiber, the intervention group. But we did find in the home environment that they had lower, they had better food in the house. So lower healthy food index in the intervention group and not the control. And physical equipment, we also found that the intervention group had more physical equipment in the house after the intervention. Then looking at their outcomes, we did find perceived stress to be significantly different. So the moms had reduced stress at the end of the intervention if they were in the treatment group. We didn't find differences in physical and mental health from PROMIS, sleep troubles, or BMI. So it's mainly the stress that's the outcome there. Then with child behaviors, we didn't find differences in dietary intake. We didn't find the sugar thing this time, which is too bad. We were hoping for that. And then physical activity, we didn't find differences, or the global health or BMI. But we did find sleep troubles, which is interesting. So they had reduced problems with sleep as a result of at the end of the intervention period. And so, yeah, we have to think about why that is. And so, so overall, we found improvement in self-efficacy for the moms, health-related self-efficacy, physical activity, and food environment, the environment of physical activity, and reducing maternal stress. And then we found a reduction in child sleep troubles. So trying to theorize why that is. You guys might have some good suggestions on this because we're writing the paper. But, it could be that the more self-efficacy the moms experience, they have lower stress, and lower stress might lead to better sleep. And so we're looking in the literature to see if we can back that up. But at least that lower stress compared to sleep could be a good relationship. And then the other thing to keep in mind is that behavior change takes time, right? And so we didn't do a time 3 or time 4. I think you need that. So, we did time 2, we had the outcomes that we mentioned. Maybe at time 3 we would see more health behaviors change for parents and child. And then maybe at time 4 we would see more of the outcomes change. It takes a long time to change health outcomes. And so I think it's a good start, but we do need more research to kind of have more follow-up periods. So, limitations, measures were all parent report. And we did consider using accelerometers, and we actually did that with our first cross-sectional study to measure physical activity. And we found that about half of the kids we had good data on. And so it's not worth doing that for an intervention study. And then, additional follow-ups. The group sessions themselves were not very well attended, although I think the control group attended them more than the treatment, because the control group got just the group sessions. They didn't get the one-on-one, 10 sessions. But I guess the treatment group felt like, well, they're already getting something. I don't know. It's a fairly small sample. I think there are some things that contributed to the success of the program, like co-developing it with our promotoras and community members, employing Latina caregivers as promotoras to deliver the intervention. And we also provided ongoing support to the promotoras, like, group meetings with both Illinois and Texas to kind of talk about cases and what they're experiencing and giving them guidance and feedback. And so, for the study, we want to thank our promotoras, of course, and our participants in the study, and lots of students that helped with the study. Very important, and of course, the contents of this, the government has nothing to do with. No, basically what that says. But it was funded by NIDLR.
My question is, did you guys look into if they had like pre-existing medical conditions like hormonal imbalances or genetic syndromes that could have led to obesity besides diet?
We did not.
Okay. Thank you.
Good question, though. That's something that should be done in the future.
Thanks, that was a great presentation. So I guess one question that I had, I thought it was really nice that you measured the home environment around food, but I'm wondering, and I know this probably wouldn't matter in the randomized controlled design, but just in terms of thinking about what to measure in these kinds of studies, a lot of families live in food deserts, right, where there's just really, you might want good food, but, there's just no food available, or it's too far away, or if you go to some of these places in kind of where the fresh fruit is like incredibly expensive and things. So how should we think about that? Did you get any sense from your interviews with families about whether that plays a role?
The promotores did a lot of problem solving with these moms. So if they did, and I don't have data on that, but if they did express that concern, the promotores would be helping them figure out, where they could go to get better quality food. So I think for all the different topics, they did that. And they also use their own experience to kind of share what they do and stuff. But that's a really good thing to measure maybe in the future. Yeah.
My question is about the control group. You said that they did do like group sessions. Mm-hmm. What happened in the group sessions?
The group sessions were kind of a demonstration of content covered, but they, for example, some of them were focused on physical activity. We actually had a Zumba for the physical activity. We had a Zumba instructor do a remote Zumba session, right, and that the whole family could participate in. And then demonstrations like how much sugar is in a can of soda, or things like that. So really trying to make the points that were covered in the intervention, but they could stand alone too. So
I had a question. Were you satisfied with how things turned out and what you would do differently in the future? And do you think the participants were satisfied? It's really impressive that you had people come and try to change their food habits, because people like to eat.
Yeah.
And so just curious about, your satisfaction with the results and what you might do differently, and whether you think people, did they buy it? Did they want to make lifetime changes?
Yeah, and I think we're looking at the goals that they set and to what extent they completed those goals. We haven't looked at that data yet, but when we did the pilot study, we had focus groups and interviews afterwards, and people were pretty satisfied with the intervention. They had some really good things to say. They really liked having the promotora, but also the goal setting. They really got into the goal setting, and they could tell you what a SMART goal was. So, which I don't know if I could do that without having a prompt, but yeah. So we got some good, positive feedback from the qualitative research, and so yeah, I do think that it made a difference and made an impact. But like I mentioned, maybe need more measurement time, more times to see what the impact would be overall, and maybe put some boosters in there too, right, to make sure that they are following some of the strategies and things.
Besides language, is there another gap we need to cover when it comes of bringing awareness about this type of services, this type of health services? Mm-hmm.
Well, I think the cultural aspect is important, and families did comment on that too. So making sure if you're talking about food, you're talking about the cultural food they eat, right? And how to maybe adapt some of that in a more healthy way, or, oftentimes they did have healthy food in the past, and moved to the United States, and there's McDonald's everywhere, but adapting unhealthy. But no, I think incorporating cultural aspects is super important in all the different things we were trying to emphasize. So for them to be able to buy into what we're teaching. I don't know if that answered your question. Other gaps could be socioeconomic status. These were fairly low income population. But even so, it's interesting how the retention rate, they actually enjoyed that one meeting a week that they did with the promotora. And so I think that was that was helpful to them.
Hi, Dr. Magaña. My name's Elizabeth. I had a question a little bit around, I think like the thought process also that, you know I'm Mexican, my family like grew up like drinking like Coke for dinner. And also thinking like more broadly that like a bottle of soda is a lot cheaper than like some organic, like fresh pressed juice. And so I was wondering, in the problem solving components of the interventions, did you find that promotoras were also like recalling helping families and like applying for like food assistance programs or like things related more to income and trying to access healthy foods versus like just the behavioral components that they could do in their homes?
That's a great question. I don't think that, it wasn't part of the curriculum to do that. So if they did it, it would have been on their own. So, but that is a really important thing to do, is to, talk about navigating services and things that they could access related to health. They actually did, I take it back though, they actually did share, we put together a lot of resources for each session that they could share in terms of like, where can you get more physical activity without having to pay for a gym, or, things like that. Where can you see a doctor if you don't have insurance? So we had resources like that. So, yeah. About the beverages specifically, I'm not sure.
I'm very curious to know like what the efforts were to recruit these families. From experience working with the Latinx community, sometimes it is hard to do that outreach and to recruit. Sometimes it's because of what's going on right now, fear of just being in some kind of database. Sometimes maybe it's the transportation or the funding. So I'm curious to know if you guys utilize some kind of like a stipend incentive, if you guys went out to the community, or how was it that you were able to reach the families in your study?
Yeah, for reaching families, we try to connect with the organizations that serve kids with IDD or that specifically serve Latino kids. We just went back to them over and over again to, can you re-advertise this again? We, tell them a little bit about progress. And, I think it helped to have organizations that, we didn't actually go in person to a lot of places. We did a lot of it remotely. And I do think because the intervention was remote, they didn't have to leave their house or worry about that aspect. So in terms of, being worried about going somewhere, and I think it really helped in having that trust with the promotora. Also made a difference in terms of that trust. And there was some word of mouth recruitment too. Chicago is really different than Texas, right, than Austin. So I think they probably use different strategies. I know Yolanda did a lot of, they have this big organization called Grupo Salto that some people might have heard of, but they have like over 500 families that have kids with autism. She did a lot of presentations to them on topics they wanted. And so we did some of that too, trying to give back to the organizations that were helping us recruit in that way. So it's a lot of work, right? Recruiting, you just have to keep at it, right? Until you get to where you need to be. But we didn't quite recruit the number we wanted. We had 55 and not 60, but yeah, it's hard.
As far as when you're tracking the nutritional for those who are on the neurodivergent, for those who are neurodivergent or even the parents, is because generally it is normacy, or what is the saying, my child may only want to eat chicken nuggets, French fries, macaroni, and cheese. When I try to throw in something that may be more nutritious, it may trigger a meltdown or other other daily stress factors that come into that. So, but also when navigating life on the spectrum is not just you have autism or you're not neurodivergent. There's some they suffer from Porter-Willis. There's some who their duodenum switch does not trigger when they are full or not. So when you're doing a nutritional value or saying other things that go into it, like obesity and different things of that sort, like how do you say, okay, well, this is how you offer your child a healthier alternative that won't cause them to have a meltdown. And me as a parent, I may have 2 or 3 other children that I have to attend to throughout my factors, so I stick to normacy. How do you expect for the parents to implement that when we are all still trying to navigate our daily lives?
That's a really good question, and we tried to consult with people like speech and language therapists or nutritionists that did specialize in that, in diet, how to introduce more food to people who maybe don't want to eat other kinds of food. And we didn't do a lot of that in our intervention because it would have taken a lot more. They were able to talk about some of these issues, but introducing small things at a time is some of the things they recommend, and not completely making big changes or forcing them to eat something, is an important strategy. So yeah, there's a lot of strategies around that the experts in that area would, have good recommendations for. But yeah, it's challenging for sure. And when we were doing this study, we didn't particularly design it for autism. We were recruiting for IDD, but it did end up being more autism, and parents were asking for those kinds of strategies.
I have a question for you. Did you factor in medication? Because some kids on autism, when they get off their medication, they are ravenous. And I know for my son, he grew.
Yeah.
And when we changed medications, he changed. So did you factor that in?
We did not, but that is a really important thing to look at in terms of just obesity in general, right?
I was really interested in that finding that it sounded like if the doctor was a little bit hesitant about a referral, then the Latino families basically sounded like didn't follow on. Is that how to interpret that?
Yeah, if the doctor was hesitant about or was more passive in their recommendation, Latino families were less likely to access services.
So I'm wondering so we are now trained, right, to be more collaborative with the family and have them help with their health care. And if you're from a culture who is seeing the doctor as the expert and not used to that collaboration, do you think that could contribute then to those disparities? I'm wondering how we manage that in terms of listening to the family, but also making sure they're feeling like this is really a thing you should do. I don't know.
No, I think that's a really good point. The fact that they might be more respectful of doctors and their opinions, and sometimes it might be that they're hearing this from the mother-in-law of the other members of the family. They're saying, oh, he'll grow out of it, and then the doctor says that, and so that just reaffirms that message. But that's why I would say that providers need to be proactive and do the referral or the screening or whatever. Don't, I think that, because I don't know, there was a study that Katie Zuckerman did where she surveyed physicians, and they did find that the physicians were less likely for Latino children to make referrals. And so because maybe they're hesitant about, or maybe they can't communicate with them well, or there might be a number of reasons why. But I think that, just making those, because a lot of times families who are more affluent, they'll ask for it. They'll make a referral for me, right? They'll insist. And so Latino families may not have that information or knowledge, and also more likely to follow the doctor's direction. So, yeah, I think just not being afraid to make those referrals. I don't think families are necessarily resistant to it. They just don't know, some of them.
I think that interaction effect between the perceived discrimination and social support is interesting and informative. I'm wondering whether you see similar interaction effect across different race ethnic groups. That's one. Two,
That's a good question.
And in terms of that perceived discrimination, whether it's specified, whether that's from relatives, family members versus people who are from non-relatives outside, whether that could be. So I'm also trying to think what's the intervention point? How can we help bring back the protective effect of that social support?
Yeah, I think we do need more data to answer your questions. We didn't look at other racial groups because we only recruited a Latino sample with that data. But yeah, it'd be interesting to see if that also plays out across different groups. But the family thing is really interesting that you mentioned, because it could be, having more social support could maybe not necessarily be good if they're people that are criticizing you or you know, are you being discriminated against? I remember when I was in Madison, we worked with a lot of families, you know, we're working on a support group, and they really brought up the concern that in their own community, they felt more discriminated against. You know, so when they went to events and stuff like that, the families in their own community were less tolerant of their child, and they felt like they were criticized a lot more. And so it could be, you know, related to that as well.
The UC Davis Mind Institute was founded in 1998 with the promise to reduce and prevent the disabilities that can be associated with autism and other neurodevelopmental conditions. Every day, our clinicians and researchers make progress on that promise. Our groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other conditions associated with disability are helping affected individuals achieve their fullest potential. Please visit our website or our social media platforms to find out more about current studies, upcoming events, and how you can help make a difference.